let's get started. Good morning, everybody. Good to see you all. Last day of the conference. How are we feeling? It's a rainy day, but you're here. Yeah, you're feeling good. That's good. Good. Well, grateful you're all here in the room to join this session with us. My name is Erica Morton. I use she and her pronouns. I'm part of the team at the Canadian Observatory on Homelessness. I am your friendly moderator for the next hour and a half. Before we get to the main event over here, I want to open up this session in a good way with a land acknowledgement. And we'll just open by saying that the 2025 National Conference on Ending Homelessness is being held in Tiohtià:ke on the traditional unceded territory of the Kanien'kehá:ka peoples. The people of the Kanien'kehá:ka Nation have lived on this territory since time immemorial. As traditional keepers of the land and waters, their culture and presence have nurtured and continue to nurture this territory. The Canadian Alliance acknowledges the many First Nations, Métis, and Inuit peoples from coast to coast to coast who participate in this conference and truly lead the way to end homelessness across Turtle Island. And don't want to make this land acknowledgement just a checkbox activity for myself or for yourselves either. So also just want to add a bit of a personal reflection and invite you to join me in this reflection. And just want to start by saying that I am an uninvited guest and a settler here on these lands, and someone who also works for a settler organization that conducts research on homelessness, which has potential to be problematic. We're working on that, hopefully, I think, at the COH. And so, yes, while I'm asked to read a land acknowledgement as a part of sort of the moderating duties, just want to go a bit beyond that and hold myself accountable. And so want to take a moment to personally reflect and invite you to join me in reflecting on our commitments and our actions that we need to be taking at this conference. And so as much as it's important to me to take opportunity at the conference to learn and unlearn and to really open my eyes and my mind and my heart to the realities of Indigenous peoples and communities and what they're facing in terms of homelessness, but also to learn about the incredible work and efforts that is truly happening. Really what's far more important is what I take from this conference after I leave and go back to my home community in Hamilton and back to my work. And so I hope you'll join me in taking one moment, one reflection, one speaker, something that you take from the conference, from an Indigenous speaker perhaps, or a session, and to really use that to continue to move the work forward. And for us to all, especially those of us that are uninvited guests, to hold true to the commitments around, decolonization, land back, Indigenous self-determination, and to be advocating with Indigenous peoples for those things. So that is my take on a land acknowledgement. So now we're going to turn things over after that moment to get to our awesome presenters who I've just had the opportunity to quickly meet, and I think you'll enjoy hearing from them all. So we're going to start off. Actually, you're all in a nice row here. This is perfect. It's like you guys coordinated this. So we're going to start off with Julie and Eric, who are going to start us off, the first presentation. Then we have William and Laurence, who are going to go next. And then Sybil, who's representing from Western, is going to be our third presentation. You'll each get about 20 minutes. I'm going to sit down here. I think I told some of you, and I'll give you kind of like looks about, okay. And going to encourage you to make sure we speak into the mic so that people watching virtually in virtual land, so that they can hear you, and also so anyone who might have audio issues can hear you properly. So I know sometimes people want to dance around, you get excited, but please try to stick to the mic, okay? We ready? Okay, come on up.
Yes. Hi everyone, can you hear me? Perfect. So my name is Julie, and today I'll be presenting some preliminary findings from a scoping review, along with my supervisor Eric Lenimer. And the scoping review was on interventions to prevent homelessness after hospital discharge. So this review was initiated by the Quebec Homelessness Prevention Collaborative, and I'd like to thank some of our contributors who contributed to the scoping review through research insights, and namely there's Laurence Roy, who is sitting right here with us. So what I'll be covering today is first a little bit of some background, and then about why we chose this topic. Then I'll walk through our scoping review methods and summarize the intervention findings, and then Eric will close our discussion. So according to a point-in-time count in Quebec, out of 10,000 hospitalized patients on any given day, 225 of them are people experiencing homelessness. So we find that many people experiencing homelessness are frequently hospitalized, often discharged without stable housing, only to return again. So we refer to this phenomenon as the revolving door. So it's repeated hospital discharges back to or into homelessness, and it reflects deep systemic gaps in both housing and healthcare coordination. So for this reason, we find that hospital discharge is a pivotal moment. So the quality of discharge planning can shape both recovery and housing outcomes. And oftentimes we find that patients without a fixed address are often lost to follow-up because we have no means to contact them. And because of that, they're disconnected from the necessary services, and they're at higher risk of returning to homelessness as well. And sometimes, going to the hospital and having some extended stays there, it can cause them to have instabilities financially. So because of that, we thought that it would be a critical window for preventive interventions. Yes. So for the methods, we use a scoping review, and our guiding question was, what do we know about interventions to prevent homelessness after hospital discharge? So in our search, we focused specifically on programs that recruited homeless inpatients recruited directly within hospital settings. And we wanted programs whose primary or secondary goal was to provide permanent or stable housing. We searched 6 databases and had 2 independent reviewers for the title abstract and full text screening, and we had a third resolving any conflicts that we might have. That was Eric. And we extracted around 37 articles, and these covered 24 distinct interventions. So a summary of our findings. We identified multiple core components for each intervention. These included whether or not they had housing referrals during the hospitalization or after the hospitalization, whether they had provided transitional living spaces, either within the hospital or in the community, and whether they provided direct housing as part of the intervention. And so most articles reported interventions focused on providing housing referrals during the hospitalization and after the hospitalization, mainly. So for the interventions, we grouped them into 9 categories. So these models span Canada, the US, the UK, and Australia, although our search was international. So the first 4 models, they prioritize continuity of healthcare after discharge, often through case management or community-based support. And while they may include some housing referrals, their primary aim was to stabilize patients' health, and the outcomes were defined broadly, so they had very little effect on days housed for homeless patients. Then the next 2 models were based on CTI, critical time intervention. So critical time intervention is a structured and time-limited model of intensive case management. It supports individuals during critical times of transitions from institutions to community living. And so here they were applied to hospital discharge. And these studies show that there was a significant decrease in homeless days or increased days stably housed. Then the next few models were offering transitional beds or specialized wards within hospitals for people experiencing homelessness. The staff, they provided on-site staff who were trained to address the needs of homeless patients alongside other clinical care. And while around half the participants were stably housed, they found that there were facility limitations and sometimes early hospital discharges. And then the next 2 models were hospital in-reach models. So there were teams of multidisciplinary teams who were often GP-led, one of which is a very renowned program, it's Pathway. So these teams, they work within the hospitals to coordinate housing, referrals, and case management before the discharge. And the study outcomes were mixed. So sometimes they had reductions in street homelessness or days homeless, and other times there were around half of the participants who were stably housed, so very varying. And the strength of this study is that it lies in early engagement with the homeless patients, and it integrated housing as part of the clinical care. Then the next two models were centered on housing in the discharge process, and they helped patients identify available options and navigate resource systems. They were focused on housing, but they didn't provide directly housing, and the results were mixed. So one of the studies showed no difference compared to usual care. It was a RCT, and the other one lacked clear outcome data. RCT is randomized control trial. The next model is actually an act, so it's a legislative requirement in the UK. It's the Homeless Reduction Act, which mandates hospitals to refer any homeless inpatients to a local housing authority. And it's the local housing authority directly who will be there to provide follow-ups for housing support after the discharge. And this study was actually stakeholders' opinions on the effect of the intervention. So we don't have any quantitative results, but they did mention that they felt that there was increased awareness and pressure on hospital staff to have more coordinated discharge practices. And the next model is one intervention. It's a St. Francis residence. So this model guaranteed a placement in a specific permanent supportive housing site, often with on-site health and case management as well. The only thing is that it was a single location and the patients had no choice as to where they had to go. And it housed everyone in a single room occupancy hotel, but it's not necessarily person-centered. And then we had transitional housing programs, so more of them. So they offer temporary housing after discharge with varying lengths of stay and levels of support. So some referred participants to permanent housing after the transitional housing, while others did not. And so again, the outcomes were very mixed because there were more of them. Sometimes there was low completion rates, and sometimes more than half were permanently housed. And yeah. And last but not least is we found 3 models who were based on the Housing First model. So they offered direct access to permanent housing, often with funding and wraparound support post-discharge. So they were the most effective in our review, with the highest rates of stable housing, and they prioritized autonomy and choice, where patients were more involved in the decision-making process surrounding, the housing options that they had at hand. And actually, this is the last. This is not one of our categories, but basically this study looked at incorporating multiple models of interventions in the UK. So it's the UK government's Homeless Hospital Discharge Fund, which funded the specialist homeless hospital discharge schemes. And multiple models were kind of incorporated around the UK in 6 typologies. So it was either only multidisciplinary case management, there was also pathway, which is incorporated, or it was providing direct accommodation with wraparound supports and funding. So again, we found kind of the similar observation that we found in our whole analysis of all the categories, is that what was most effective out of all of these models that were applied was combining multidisciplinary case management with direct discharge and continuous funding to appropriate accommodation. So yeah, more than almost all of the participants were housed in these cases. And this approach reflects the benefit of system-level investment in flexible and multi-model solutions. And it's interesting because applying multiple models in one area can, help us understand how can offer insight as to what might help the most in a specific country. So I gave a really quick overview of the models due to the limited time, but if you're interested in knowing more about some of these models, we have extracted all of these articles in more detail, so after the session I would love to talk more about them with anyone who'd like to talk about them. And in the meantime, I will hand it over to Eric to conclude.
Thank you, Julie. Okay, so so our conclusions then are several studies relied on RCTs, some on pre-post designs. There were some instances, I guess I'll preface by saying it really has been a struggle to make sense of this literature because kind of every one of these interventions is a bit different from each other. And so the process of trying to group them together, I think inherently has some subjectivity in it. And the outcomes are not necessarily the same, even among interventions that look a little bit similar. The outcome measures are different. So some of the comparisons lead to the conclusion it doesn't seem to make that much difference whether your main aim is to house people or it's a secondary aim, the primary aim being connecting people with healthcare. But what does seem to emerge was the final model that was presented, and it's hardly surprising, one where kind of you contact the person before they're discharged and you accompany them to what you intend to be their final housing, and you have the resources to be able to enable them to stay in that housing. That works. That works. So it's not necessarily housing first. Housing first is a long-term intervention. People don't necessarily need the long-term supports, but kind of you need to be able to provide them with housing that they can afford. And so at the end of all this work, we come up with a conclusion that I think is kind of common sense. So in terms of practical and policy implications, well, kind of as Julie mentioned at the beginning, kind of quite a number of homeless people go through hospitals. And so it's a relatively it's one way to find people who are homeless is to meet them at the hospital and then accompany them into housing. It's one mechanism we can put in place to reduce homelessness. But we need access to affordable housing, which of course everybody here knows is an issue. So thank you. We're done. Thank you.
I'll just, I just want to include the references at the end so that if anyone wants to look at the article specifically, they can. Sorry. Perfect. In the recording. Oh, they're available? The slides? Oh, perfect. Perfect, thank you.
All right, so let's just gear up here for our next presentation. Also, I forgot to tell you what session we're in. So just so that I know that I did this and no one's sitting here being like, where am I right now? We are in Housing First, Health Always, Uniting Housing Solutions and Health Strategies to Prevent Homelessness, which was so excellently just modeled here by Julie and Eric. So hopefully you're in the right room. You're welcome to stay if you're not. So we're going to have William and Laurence join us up next. Slides are ready to go. And take it away. Thank you.
OK, bonjour tout le monde. Merci d'être là à la session. Hi, everyone. Oh, this is going to be in English. I just want to say hi. Thank you for being here. Thank you so much for your interest in the intersection between acquired brain injury and homelessness. I'm really excited to be here. So I'll try to be a bit less excited because I tend to get myself worked up when I talk about ABI and homelessness. Up front, I want to say this can be challenging for some people. To discuss acquired brain injury, this may be an experience that you've had yourself. This may be an experience that some of your loved ones have had. So we're going to talk about this today. Also, I want to say that the intersection of acquired brain injury and homelessness is not something that's theoretical or even clinical only. I just want for us to take a moment to acknowledge Raphaël André, who was an Indigenous man here in Montreal who passed away very close to here in January 2021. There was an inquiry into his death, and one of the conclusions of the coroner report was that acquired brain injury was a major obstacle to care that actually contributed to what happened to Mr. André. So just want to maybe take a few seconds to acknowledge that. Okay, so there's a... Yes, it's a point-by-point thing. So no, everyone knows homelessness is increasing. We also all know that there's a disproportionately high morbidity rate. So health issues are prevalent, and what we often hear is mental health and addictions. Right? We're always like, and I think in the public eye in the media, what's out there is like, well, health problems among people experiencing homelessness is mental health and addictions, which is not untrue, but it's a very reductionist view of the morbidity within this population and also impedes access to care. So one of the health issues that is well documented actually, but unlooked at, is acquired brain injury. We know from previous meta-analysis that there's a 53% rate of traumatic brain injury, and that doesn't even include other non-traumatic. Is everyone clear on the difference between traumatic and acquired brain injury? Just raise your hand or like tell me if you're unclear. Okay, good. So acquired brain injury encompasses traumatic brain injury, so a hit to the head, and that has consequences. Non-traumatic acquired brain injury would be something like stroke, a brain tumor, so anything that's acquired throughout your life and that will impede your brain function. So just to put everyone on the same page. So that's just for the traumatic piece, is over half of people experiencing homelessness over the lifetime will have acquired traumatic brain injury. And what's even more preoccupying, I should have said that at the beginning, but we're both occupational therapists, so this is a preoccupation for us. What's even more preoccupying is that over 1 people in 5 experiencing homelessness have moderate to severe traumatic brain injury in their path. So that tells us that they're probably living with some residual symptoms and challenges directly linked to that, and we're going to see that in the presentation. So just to give you an idea, moderate to severe brain injury is about 2 to 3% in the general population. So that's really, really, really high. Very preoccupying. Another thing that kind of challenges us is that in the studies reviewed, we know that most people have experienced their first acquired brain injury before their first episode of homelessness. So we know that being homeless, living in poor material conditions can expose one to acquired brain injury. You get, hit in an assault or hit by a car. There's multiple instances where that can happen. But for most people, the first acquired brain injury is before homelessness. And so that speaks about prevention practices. That speaks also to maybe the failure of some of our ABI services to kind of catch people before they go into homelessness. We don't know a lot about turning points towards homelessness. It's an understudied population apart from the prevalence rates and like kind of the causes and symptoms, but we don't know so much about the experiences of people. We also know from previous work in the area that the Quebec healthcare, and I don't know about other provinces, and can discuss that after. There's a question period, right, at some point. Okay, good. So this is my first conference. I was teaching the other 2 days, so I couldn't be here, so I'm kind of getting adjusted. So we know that in Quebec, acquired brain injury is often seen as an episode of care, like an épisode de soins for the francophone ones in the room, and that's a problem because people actually live with chronic needs that need to be addressed, and then they kind of fall in between the cracks. We also know that conversely, healthcare needs are poorly addressed, like within our system of care. When people are experiencing social adversity or homelessness, there's many, many barriers to having accessible and adequate care for this population. So what did we do? In 2022, there was a call for proposal from the Quebec government where the issue kind of identified that this was a challenge. I think we had like an ally at the level of the ministry who was someone really concerned about this specific issue. So we got a 1-year funding with this amazing team of people. I'm not going to name them all. To do some synthesis of what do we know about the experiences of people experiencing homelessness and acquired brain injury. So today we're just going to present a portion of those results, because otherwise we could be here like until 9. So we don't want to do that. But just want to acknowledge some are in the room here. We were so lucky to have many collaborators from community organizations, healthcare institutions to help us do this work. So I'm gonna hand it over to William.
Hello. I just want to say I think I'm the only speaker that my English is not it's not bad, but it's not great. So if anything I'm saying is not perfectly clear, just like look at me maybe like this and I'll try to rephrase it. So our objectives with this study were to understand the key moments and the turning points towards homelessness for people with a history of both homelessness and acquired brain injury, and also identify the needs, facilitators, and barriers to accessing health services for this population. And to do so, we did a qualitative descriptive study. I'm not going to go in details about the method. It's not that interesting. For the recruitment of our participants, we worked very closely with our community partner organizations in the cities of Montreal and Quebec City. I'm very thankful for these organizations. We couldn't have conducted this study without them, so thank you. Merci, Isabelle. To be included in our study, participants had to be aged 18 years old or older, be or have been homeless in the past 5 years, and have at least one suspected or diagnosed acquired brain injury. We did not ask for a proper diagnosis, and I will explain why very shortly. So for data collection, we started with the completion of 2 questionnaires, basic socio-demographic questionnaire with questions about like gender, education level, etc. And then we did the Ohio State University TBI identification method, which allowed us to describe all the acquired brain injuries that the participant had sustained in his or her lifetime. So this is why we didn't ask for proper diagnosis, because we know that most of the people experiencing homelessness who have sustained one or many brain injuries don't have a diagnosis for various reasons. Didn't want to go to the hospital, couldn't find a doctor, didn't think it was bad enough, didn't need medical attention. So most of them don't have diagnosis, and with this questionnaire, with the Ohio State identification method, it really allowed us to fully describe all the brain injuries that the participants sustained. And then we did individual interviews using the life history mapping method. So basically, we asked the participants to, we started with the first place they remembered living. We asked them to represent that visually on a piece of paper. And then we asked them to identify key moments in their life history regarding their brain injuries, their residential pathways, the services that they received or would have liked to have received. And at the end, we asked them to look at their life map and identify potential interventions to be taken to prevent homelessness. All of these interviews were audio recorded and transcribed into verbatim, and we did an analysis using Payet and Muccelli's framework. So this is an overview of our participants. We met with 26 people in total, 16 male, 10 female. Our youngest participant was 21. Our oldest was 68. We had diversity regarding migration journeys and sexual and gender diversity as well. The average number of acquired brain injuries sustained by our participants was 4.4, so that's huge. Most of them, so 77%, had sustained a first brain injury before they were 18. And almost half of them, so 12, had a period of repeated head impact. So whether it be because of contact sports or period of violence in their lifetime. And we counted these periods of repeated head impact as only one brain injury because we couldn't identify how many there were really. A stat that is not in the slides but is very telling, all of our participants, so 100%, had sustained a first injury before their first episode of homelessness. So 4 main themes emerged from our analysis. I will go through them individually, but experiences and services, friends and family as a residential safety net, acquired brain injury as a barrier to exiting homelessness, and complex housing and accommodation needs. So for experiences in subteam, we have in services, we have a first subteam, which is the non-use of care, which was a common and frequent experience, including for probable brain injuries. So after getting hit to the head or after symptoms of a stroke, for example, people did not seek services. And there were many reasons that were told by our participants to explain this non-use of care. But the main reasons were previous negative or traumatic experiences of services, the belief that their health condition would not improve or worse could deteriorate if they went to get services, a low tolerance for the hospital environment, so difficulty with bright lights, loud voices, lots of people, and also the rules that come with hospital settings, so not being able to smoke when you want, not being able to use substances. And finally, our male participants also talked about a certain pride in managing their symptoms alone and not wanting to ask for help. Most of the participants we met have positive links with at least one community worker or one team from outreach services in the areas of homelessness, mental health, or addiction. The community environment was described by our participants as caring, conducive to building trust, and as meeting many of their needs. However, our interviews showed that these services are not enough to meet people's complex needs, particularly health-related needs and needs that are directly related to their acquired brain injuries, so cognitive difficulties. And some participants were even excluded from these services because of difficulties that can be directly linked to their brain injury. So here we have a quote from our participant, Catherine, who talks about the training of community workers relating health needs. I'll let you read it. I won't read it. I will read it. So she says, I understand that in places like this, there are no specialized people who have, well, not specialized, but who have training in care. And that's not just for brain injuries, whether it's any kind of care. I find that the training is too technical and too regulated, which means that they have difficulty adapting to specific cases. Sometimes you're dealing with a caseworker who doesn't know what to do. Another sub-theme for the experiences and services is the non-recognition of the acquired brain injury. So a number of our participants reported that they didn't have access to proper screening, assessment, and referral services for their brain injuries, particularly in judicial settings. And for other participants, when they sought help from the general services, so in emergency departments or with their family doctor, for example, all their symptoms were attributed to their substance use. And as a result, people were not getting the services that they needed, that was adapted to their needs. So here we have Ijid. He says, well, the family doctor thought I was just like a junkie and that I wanted drugs and that all my symptoms could be explained by my drug use. So his use of cannabis. He said that I stuttered because of cannabis. He said that I had migraines because of cannabis. He said my addiction problems were due to it. You know, everything. And Ijid went to see his family doctor after sustaining multiple traumatic brain injuries. Our last sub-theme for the experiences and services is that the acquired brain injury specialized services are poorly adapted to social vulnerability. So the acquired brain injury emergency services are perceived as quick and effective by our participants. However, many deplored the lack of follow-up from the health network following this initial episode of care, despite persistent and important symptoms. For other participants, hospital stays or stays in rehabilitation centers were described as poorly adapted to their social situation or the state of their mental health. Here we have a quote. I just want to say before, that's from Buck, one of our participants who sustained a severe traumatic brain injury and who was in a coma for several weeks when he was in the hospital. And then he got sent to a rehab center. And this happened a few days after he arrived in the rehab center. So he says, I was in rehab and I went outside to smoke a cigarette and it was windy and I smoked my cigarette and everything and I don't remember throwing it out. Anyway, to make a long story short, I went back into the rehab center and I was starting a fire. The cigarette had been blown on me and so I got expelled. So Buck did get expelled from the rehab center. He was already homeless before this episode of care and he returned to a shelter with no further services at all. Our second team, friends and family, as a residential safety net. So many participants spoke about the presence of a family member. Often it was a parent and often it was a mom. So they spoke of this family member as a protective factor against homelessness and as a residential safety net that was present throughout their lives. However, many of our participants saw their family ties erode over time for various reasons, including the death of a family member or relationships that have deteriorated because of the person's behavior, so impulsiveness, substance use, and some of these behaviors can be directly linked once again to the acquired brain injury. Our third team, so acquired brain injury as a barrier to exiting homelessness. So our participants reported a variety of symptoms related to their brain injury. So here are a few symptoms: memory loss, difficulties with sustained attention, organization, problem solving, chronic pain, hypersensitivity, fatigue, motor and language difficulties. These are just a few of the many symptoms that were named by our participants. And these difficulties can greatly reduce a person's ability to function in homeless community settings, but it can also hinder their ability to obtain and maintain proper housing. So let's just think about being able to pay rent, with difficulties with sustained attention, relations with neighbors, when you have impulsivity problems. A few examples of how it can hinder their ability to maintain housing. And finally, our last team, complex housing and accommodation needs. It's related to what I just said. So our participants had several symptoms, which explains why they have difficulty functioning in group community environments. Post-hospital stays in group environments also hinders their recovery. So, for example, we had a participant who talked about she had a brain tumor, she got operated, and the next day she got discharged from the hospital, went back into a shelter, and couldn't sleep at night because of the voices. So she was not able to recover from her brain operation. And several participants spoke about their housing needs and stated that they need housing that is adapted to their disabilities and other medical conditions. And here we have Egid, who said, since I have more of a focus barrier, well, when I'm in really stimulating environments like the day center, where there's sometimes two different types of music, people are talking, they're shouting, there are lots of smell, the light is bright, the more stimulating the environment, the more it interferes with my own thoughts. And then because I'm having trouble thinking, well, I get kind of frustrated. I'll let Laurence continue.
2 minutes? Yeah, okay. I'm just going to go through it. I can adjust. About 2 minutes? We're good. I just want to say that there was not a direct pathway into homelessness from ABI. So for two groups of people, so around half our sample, brain injury was kind of directly linked to their episode of homelessness. For a part of the participants, that was through behavioral consequences. So there was a before and after the brain injury where they got more aggressive, more impulsive, more irritated, and that quickly actually led to erosion of ties with family and friends, and also justice involvement. For other participants who were older, mostly female, the brain injury was associated with more of functional challenges, difficulties being able to work, pay rent, all of that quickly led to homelessness. For about a quarter of the participants, it was really hard to disentangle brain injury from all of the other consequences of violence that they experience in their lives. So this fourth category where people had been exposed actually to violence as children, as teenagers and adults, and that was just ongoing with all the multiple like physical, health, addiction-related consequences of violence. So that's something to keep in mind if we're thinking about preventive interventions. Then for a fourth group of participants, brain injury was less at the forefront, so other factors led into the pathway to homelessness. But for those, ABI acted as a barrier to exiting homelessness, as William mentioned. So I actually just went through all of those very quickly. So what do we need to do? Well, I would say kind of the take-home message I'd like you to bring back to your organizations is that we need to start paying attention to brain injury in this population, whatever the setting you're thinking about. So that's kind of the big take home. We've identified three, in our report we have 13 recommendations. So if you read French and you want to know more, we have a huge report. But I've summarized that into three main needed changes. So the first one is really recognizing acquired brain injury as a chronic health condition that we need to follow up people over time. For those who, like Buck, for instance, go through services and are kind of lost somewhere and become homeless or remain homeless. So we need to do that, and that's at the level of policy and Canadian and Quebec policy. For those who don't get access to healthcare, we also need to support the community organizations, and a lot of that responsibility is through healthcare and partnership between healthcare and community organizations. We have expertise in how to manage and treat acquired brain injury. It's just that it hasn't trickled down in the community organizations, and so that's a big priority for us. And also be able to kind of connect sectors like the homelessness sector and the physical rehabilitation sectors. They've been very, very far from each other. And we present this. Like you guys are like calm and okay, yeah, we know this. But we present this in physical rehabilitation settings, and it's like something completely new and surprising, which is okay because they haven't been in contact with the homeless sector. But this is one of the big goals. So I think I've said all of that. So thank you so much. Sorry for the little going over. Thanks. No, that's not. Yeah.
Okay, thank you. I feel terrible being the moderator when I have to cut off good conversations, but I'm sure William and Laurence can chat after if folks want to see what else was on those slides. And just want to say thanks for your work and for helping to fulfill information gaps and research that are needed for folks with brain injuries, and looking at what is needed in the sector. And I feel like there could be combination between our first and second presentations with scoping reviews and what does that look like when you factor in brain injuries. You guys could do a collaborative project.
We do know each other. So.
Oh, sorry. Okay, you're like, stop, Erica. We know what we're doing. You don't. Okay. Hi, Sybil. Come on up. You ready? Yeah. Excellent. Hang on. Let me get this started here. There's a blank slide here. Is that? Oh no, the next slide, it pops up. Yeah. Okay. Oh, I'm giving it away. Sorry. Thank you.
So I guess it all came. Good morning, everyone. My name is Sybil. I'm a PhD candidate in nursing at Western University. I work with Dr. Abe Altshorn. Today, I'm sharing findings from our Ontario Alliance to End Homelessness research project, led by Dr. Abe Altshorn, titled, "What Would It Really Take to Prevent and End Homelessness in Ontario?" But our discussion today centers on one crucial question. How can mental health supports be effectively integrated into homelessness prevention policy and practice, not treated as a separate crisis stream? Right now, we still design systems that treat homelessness as a downstream emergency and mental health as something to be managed in emergency departments. Our data suggests that this framing, this crisis reflex, is exactly what keeps system reactive instead of preventive. So here is our roadmap for today. I'll start with some context and methods, then share 3 main findings: the broken system, gap between policy tools and reality, and the human cost of disconnection. And finally, a model for integration with concrete policy and practice recommendation. So let's start with some background. Despite 2 decades of housing first rhetoric and the promise of Canada's national housing strategy, both homelessness and mental health challenges continue to rise across Ontario. So even with all talk about prevention, the numbers keep climbing. That tells us that policy frameworks alone are not enough. Something deeper in our design logic still needs to change. So, when it comes to problem, here is a quote of one of the participants. "We are treating mental health like an emergency department, not a prevention system." So this actually captures the core of what we found. Mental health supports are still siloed, reactive, and disconnected from housing prevention frameworks. Funding and governance exist in separate pockets, producing parallel systems. They run beside each other but rarely meet. And when systems don't meet, people fall through the gaps. Our main question was simple but also huge. What would it really take to prevent and end homelessness in Ontario? Within that, today, we focused on one key piece of the puzzle. How can mental health supports be effectively integrated into homelessness prevention policies and practices? We conducted 70 semi-structured interviews across Ontario with a diverse group of participants: people with lived experience, policymakers, service providers, researchers, and advocates. We used descriptive content analysis, followed by interpretive sentences to move from what's happening to what needs to change. And we examined everything through a prevention lens across 3 levels: macro, policy and governance; meso, system design; and micro, frontline practice. So when we asked participants what's broken, the answers were almost identical, no matter who we talked to: people with lived experience, policy folks, service providers. 3 items came up again and again. Mental health and housing still operate as parallel systems. Funding and accountability are fragmented. Rights talk doesn't translate into real remedies. So let's unpack those. First, parallel systems. At the policy level, one participant mapped it out as there is absolutely no overlap between healthcare and housing and homelessness policy. 2 systems, 2 streams, no bridge. At the practice level, people don't experience a system, they experience agencies. So when someone becomes homeless, they don't touch a system, they touch an agency. That fragmentation feels like having to tell your story over and over again, restarting every time with no one holding the thread. In many cities, hundreds of small organizations try to coordinate without shared structures. Second, fragmented funding and no shared accountability. As one participant said, you can't coordinate your way out of lack of housing. So process reforms and better referrals don't solve resource gap. Without deeply affordable housing and stable income supports, coordination just reshuffles scarcity. Governance is equally fractured. Homelessness sits across municipal, provincial, and federal jurisdictions, but no one owns the whole picture. One participant described it as policy in the wind. No shared standards, no timelines, no consequences, which means no accountability. We saw the consequences in the justice and health transitions, people released from custody or hospital directly into homelessness. And even one participant argued that there should be legal liability when public systems discharge people to the street. So, third, rights without remedies. Symbolic wins look good on paper, but don't change outcomes. By Nameless is a perfect example. A valuable data tool, but without actual housing stock, it can't move people out of homelessness. Frontline workers describe the moral injury of promising exists that don't exist. During COVID-19, when housing became a true enforceable right, systems suddenly moved fast. Hotels were leased, supports were funded, and people were sheltered. That's what happens when rights have remedies attached. So we have parallel system, fragmented funding, and symbolic rights without real power. If we want different outcomes, we need to stop building parallel and start building one prevention system with shared accountability and real consequences. Now let's talk about what this fragmentation does to real people, the human cost of disconnection. When mental health and homelessness systems run on separate tracks, crisis replaces prevention, delays pile up, people disengage, and preventable tenancy loss becomes a symptom of system failure. So we're still organizing mental health response like an emergency department. Everything is reactive. Communities keep investing in crisis management instead of upstream solutions, even though prevention is possible and cost-effective. The tools we use, coordinate access by name list, are supposed to improve efficiency, but as many participants told us, they just often ration scarcity. So as one participant said, we only need prioritization systems because we don't have enough housing. Fix this shortage and scaffolding becomes unnecessary. When it comes to delays, in triage system short on housing, people with moderate needs wait the longest. As they wait, their situations worsen. Moderate needs become high acuity needs. Delays translate into harm. We repeatedly heard about people discharged from hospitals, corrections, or child welfare directly into homelessness. Different systems have separate data platforms that don't talk to each other, so coordination depends on luck rather than design. When it comes to disengagement, language barriers, literacy gaps, and technology issues make it nearly impossible for many to navigate multiple systems. Eviction prevention programs that look strong on paper often becomes a maze of phone calls and intake forms in practice. People calling 10 different agencies while under the threat of eviction. So eventually tenancy loss, when people have to self-integrate disconnected programs, eviction becomes almost inevitable. So participants were clear. Homelessness must be recognized as a system failure, not an individual one. So, and accountability must be shared across housing, health, justice, and child welfare. So, what integration looks like? This is the turning point. What it looks like when systems actually work together. To truly prevent homelessness, we must stop pretending that mental health and housing are separate. They are inseparable. Housing is a health issue. When someone loses housing, mental health deteriorates. And when mental health declines, they lose housing. You can't stabilize one without the other. Integration means designing systems as if that connection is self-evident. So in practice, integration looks like clinical and tenancy supports delivered together, not separately, treatment hubs that bring healthcare to where people are, where staying well and staying housed, and shared goals. Shared ownership of outcomes, hospital, housing providers, and municipalities co-own the results instead of simply referring people between them. So integration is about shared purpose, effort, and results. And this, it has to reach beyond homelessness services across health, justice, child welfare, and education. Because every one of these systems contributes to who ends up homeless, as we know. A key test of integration is discharges. No one should be discharged from any public system to the street. That's the baseline of accountability. So how do we get there? It starts with provincial leadership, clear directives, shared data standards, and interministerial accountability. They also give example of Quebec. Like Quebec provides a strong model, multiple ministries working under one coordinated plan. Consistency also matter. Shared training, metrics, and ethical data across regions, embedding indigenous data sovereignty and equity from the start, not as afterthoughts. At the individual level, integration means asking, what's really driving this person's crisis? Trauma, poverty, disability, violence, and connecting them to the right supports and stable housing together. So, but without integration without sufficient supply is just rationing. We need deeply affordable housing and ongoing supports to make coordination meaningful. So integration means one prevention system here. Health and housing operate together, ministries share accountability, discharges to homelessness are eliminated, and equity and data ethics guide every layer. Let's turn from ideas to action. Who needs to do what, at which level, and to make this real. Integration isn't abstract, it's operational. From the provincial level to the front line, every layer has a role to play in building one prevention system where housing and mental health supports work together. At the macro level, there is provincial leadership. You can't coordinate your way out of a lack of housing. Provincial leadership must fund housing and supports together, which means capital plus care. Where this has been done, results followed. For example, One Ontario community now has 72 new supportive units built on this integrated model. No discharge to homelessness must be a non-negotiable value with accountability mechanisms if it's violated. Set clear standards, timeline, and targets so local systems aren't policy in the wind. All ministries under one prevention plan that brings housing, health, justice, and education into shared accountability. And it's important to recognize that restructuring isn't free. If you're going to shift services toward community-facing prevention, that will require additional resources. At the meso level, community and system design, integration here means real collaboration, not just coordination meetings, as act as one ecosystem, not competitors in the same space. Use data ethically with indigenous data sovereignty and anti-oppressive design, but always pair data with supply. A list without housing is just a waiting room. So learn from the success stories. For example, Niagara's cross-system collaboration, York Region's peer support through Craftsman Center, Inval's tired supportive housing model. So these examples show that Ontario already has some effective models. The problem is scaling them across municipalities and embedding them into provincial policy. At the micro level, which is frontline practice, integration has to live in everyday practice. Case-by-case assessment should ask what's really driving the crisis and respond accordingly. Protect the middle. Don't let people deteriorate until they qualify as high need. Manage transitions proactively. A single phone call between the systems can prevent the discharge into homelessness. And finally, center lived expertise, not as a storytelling, but as co-governance with peers paid and empowered as decision makers. So bringing it all together, at the macro level, fund and align systems. At the meso level, connect ethically and measure consistently. At the micro level, follow through with tailored and coordinated care. So we have a visual based on the research we did, and this illustration maps the multi-level system required to end homelessness in Canada based on insights from national and Ontario-based research on coordinated access, system navigation, and intersector collaboration. So this image shows actually macro, meso, and micro layers of policy and practice. At the macro level, top, the foundation is public leadership and sufficient funding across all orders of government. Clear structures of responsibility, like organized bureaucracy, must align housing, income, and social policy, while correcting structural injustices such as colonial legacies, gender inequities, and the financialization of housing. A comprehensive housing strategy with market, social, affordable, and cooperative options must integrate with robust income supports, such as basic income and social assistance. At the meso level, middle level, This layer represents the operational system that coordinates people, data, and services. A well-designed, coordinated access system and by name list connect housing services like shelters, transitional and supportive housing, rent supplements through strong planning, land use, and prevention mechanisms. Integration with other systems like healthcare, justice, child welfare, and mental health is essential to stop discharges into homelessness, to share responsibility, and to share responsibility for outcomes. Sustainable planning also addresses financialization, intensification, and land policy to ensure housing stability. At the micro level, the bottom one, this level reflects frontline practice and community delivery. The right mix of services and acuity-based practices like harm reduction, gender lens, lived experience, leadership, indigenous and refugee-led supports ensure person-centered, culturally competent responses. Navigation, outreach, and peer supports bridge people to stable housing, while tools such as eviction prevention, youth support, housing first, and rent supplements provide the tangible mechanisms for recovery and stability. So across all levels, arrows and pathways shows that coordination, acuity, and accountability must flow both ways. Funding and policy move downward, while data, experience, and lived expertise move upward to shape continuous improvement. So this visual illustrates that ending homelessness is not the work of one program or ministry, but a connected ecosystem. One that links housing, health, justice, income, and community well-being through shared purpose, equitable design, and sustained investment. Thank you. Yeah, sure. Yeah, that's fine.
We're going to keep that up because I think it's cool. Thanks, panelists. You did a fabulous job. I know we can clap again. Sybil, I appreciate you taking such a sort of broad concept and bringing it down so succinctly. I definitely heard some in the audience as you were talking, and I'm imagining that while your work was focused on Ontario, assuming we're not all from Ontario in this room, that other folks from outside Ontario are like, this sounds pretty familiar. Yeah, same thing. I had another thought, but I lost it. It'll come back. We're just going to move into the Q&A now. So we have, yes, Natalie, there you are. So Natalie's got a mic. It's ready to go. We're asking folks to do questions via the mic. So questions, comments, thoughts, go for it.
Hi. So one of the things that we find is within the homelessness system, obviously we get to know the people who are in the shelter really well, and they know some of the traumatic experiences they're having, that they suspect sometimes that there's been an acquired brain injury or traumatic brain injury. But we aren't health providers, and so sometimes it's difficult to try to bring a suspected diagnosis to the health system and have their opinions valued. We find that a lot, actually, and so as health professionals who are obviously well-versed in this, I'm wondering if you have any tips for our system and how we can communicate and advocate in a way that we're going to get better responses.
Can I use this one? Sorry, it's just too short. Yeah. Okay. So can I ask where you're from? Ontario, okay. So it's a little bit hard because the healthcare system is quite different, like in every province. But and I just wonder if the obstacles that you're facing is from people who have experienced brain injuries not wanting to go towards healthcare or healthcare actually being misadapted, traumatic. Yeah, staying right. So I think one of we work on another project with domestic violence survivors and brain injury, and one of the things we're trying to do right now is building an ecosystem between brain injury rehab and healthcare providers, including like emergency departments, rehab professionals, like this continuum of brain injury care, and bringing people closer. So some of the things we've been doing is identifying which emergencies are best equipped actually to have people who have brain injuries, because not all emergency departments, for instance, are equal in their knowledge of brain injury. So that's one thing. And not all the emergency departments are equally equipped to welcome people who might have social vulnerability or be homeless. So that's it's a very basic thing, but just identifying who your allies can be within the healthcare system is one step. And I would say that it takes time to build that ecosystem, but things like trauma-informed practice, just like knowledge about homelessness in the healthcare system is what is needed, because things are not going to move before presentations like this. We do presentations like this in the healthcare system, and that really changes the lens, where they see that, okay, so this person may have behavioral issues, or this person may not fit within our system, but that's actually a medical issue, and that's not. And again, like, it's so complex because we don't want also to further stigmatize substance use, but healthcare providers need to kind of move away from that idea that everything is attributable to substance use, and that substance use doesn't have a function. It does, right? You know that. And a lot of people we haven't had time to mention that, but a lot of people have had brain injury in the context of either violence or a car accident. They have other physical health consequences, and a lot of them are dealing with pain and managing their pain through substance use, and this might be the lens that healthcare providers are not having. So yeah, that, I don't know, it's hard to change system, but I think more knowledge to the healthcare system, like emergency departments and first points of contact for brain injury, are crucial. So does that kind of answer your question? Okay, good.
We have a lot of questions. So we have one here, and then one here, and then one over there, and then one here.
Especially.
And one at the front. Yeah. Okay.
Hello, thank you very much for sharing your talks today. I had a question about integrating case management before discharge from healthcare systems. So I'm come from Red Deer, Alberta, where we're seeing an increase in clients on our coordinated access list being discharged from treatment centers and hospitals. And so when there's been attempts to connect with those systems, they work in silos right now, unfortunately. But when there's been attempts to connection, kind of the pushback that we've received from healthcare providers and treatment centers is around client confidentiality and limitations in data sharing between systems. And then also sentiments around, fidelity to the programming that treatment centers provide specifically for substance use. So just wondering, how can we overcome the data sharing component between systems, where even if an individual client is consenting to their data being shared with their case manager, if there is pushback from a provincial health board and that being and that happening? Yeah. Thank you.
Well, that's a challenging question. I don't have a very good answer for that beyond, like, obviously it would be preferable if the data were shared. So in some systems, what they've done is kind of an opt-out. So by default, the information is shared, but you have the option of kind of opting out so that you can choose that your information not be shared. So, but honestly, I mean, we have our literature review has not looked at that question specifically. Unless you want to add something, Julie.
Yes, well, we did include like the limitations that we found in some of the interventions, and they mentioned this a lot, where they found that, the hospital databases, they weren't easily accessible. And that's why the things that work the most for these interventions is when there was effective coordination between the hospital and the case managers here. And I think that one of the things that helped the most was to have like already a system in place where the hospital itself knows that, look, there's a team that's going to come and that's going to need to have that information. So just making it mandatory to, or at least known to raise awareness about the fact that we need more housing case managers and more integrated teams like Pathway and Reach teams. Or you mentioned that you work in this field. Where are you working?
I work for the city of Red Deer in Alberta, so I coordinate our working access system and outreach to other systems too, like healthcare system.
Okay. And are you?
It's been difficult to make those connections when those systems are operating at different levels of government versus like coordination with local community organizations has been excellent in our community, but that there's been
It's always healthcare.
struggles with that.
Yeah, I'll just add one thing. Like, this is not completely different from like assertive community treatment teams in mental health. So if the assertive community treatment team is kind of part of the same healthcare system as the hospital, it's quite natural and almost a matter of course that the information is shared. So you could totally imagine like a team that is part of the healthcare system that kind of meets the person at the hospital and then accompanies them into housing. So I realize that there often are barriers between like community organizations and the institutional sector. That's the challenge. But yeah, there's no easy answer to that one, I'm afraid.
Good question, though.
Thank you.
Yeah, Steve.
A question for you, Sybil. I'm Steve Rolfe. I'm from Indwell, so thank you for mentioning Indwell. I'm going to wear my Indwell hat for a second, and I think what I really appreciated in the conversation, and in all three conversations, two things. One is that all three presentations tended to have a theme where people are experiencing a kind of disability challenge, complex health issue that is not episodic. It is not going to go away on its own, and there is clearly a difficulty of providing a kind of care that meets those needs across time that's not transactional. So that would be one observation. The other is, because the system looks that way, the work that I'm doing with going to the ministry and actually asking for the integration of funding is in itself insular. And it's like you're going into a box. And you go into the box, you stay in the box, and you're looking for whatever it is you need for that particular program. But I'm also keenly aware every time I talk to other providers, they're doing exactly the same thing at the same time. So in your interviews with the 70 participants, did you get a sense that we actually know each other and what we're actually doing? Like, I guess that's the piece that I always dream about, is that someday we'll actually just all wake up and decide enough is enough. Let's get together and actually do strategic initiatives around ending homelessness. So I just wondered if that came out.
Yeah, it's we had a diverse population, and as far as I remember, like everybody was kind of pointing out the same problems. But I think the solution is the coordinated access system, so everybody can see what others doing or what others want to do, I believe.
Thank you. There was over here. Oh, okay. Sorry, you're next. Yeah.
Hi, I'm Jessica. I work here in Montreal. I want to thank you all. Those were fantastic. I love the systems stuff that like really tickles a little part in me, and I love your visual. My question is actually for Laurence and William. I'm going to try and phrase this so it makes sense. So I learned a lot from your presentation, and I'm grateful for it, and I'm going to go and find I don't know if I'll read your whole document in French, but I'll do the best I can. With people experiencing homelessness, there's a lot of what we say in Quebec, des comportements dérangeants. I do a lot of support for the system as well as community organizations. I'm there to sort of facilitate access to services. I support the people who support the people experiencing homelessness. And so I get a lot of calls around comportement dérangeant, which I guess translates to English to like bothersome, disruptive behaviors. And they're like, well, they need long-term care because they're old and they have cognitive decline. Like everyone's sort of micro-diagnosing themselves. And I'm talking about the community at this point, so the community organizations. Yep. So the stuff we've learned from your presentation around traumatic brain injuries, acquired brain injuries, is there a way to facilitate that kind of learning to community organizations, to citizens of Montreal? Because I get contacted by citizen groups too. Well, there's this person and they're really loud, and why isn't anyone doing anything? We keep calling the police, and so I have to help them understand the difference between dangerosité et dérangeante. Yep. So the difference between like dangerous behavior for themselves or others, or are they just really annoying, but they're not actually dangerous, they're just loud and they scream a lot and it makes you uncomfortable. So I feel like what you've just presented, like the data is just mind-blowing. How do we take that data and bring it to like a level where the community organizations are hearing it, and how do they then find a way to adapt the fact that it's a shelter or a day center or whatever it is? How can we help them understand better, but then also adapt how they're interacting with the clientele to maybe help them a little more, as opposed to like barring them from services and just creating like this other nebulous cycle of awfulness? Does that make sense?
Yeah, no, it does.
Thank you.
I'm gonna let William answer, but we're gonna invite you to something at some point. So just remind me. Just spot yourself more work.
I can start, but you can complete maybe. But we're doing like a lot of work. We're presenting these results like very often. It's like maybe I don't know, 20th time, like in community organizations, with the police, in the healthcare network. So we're doing like a lot of word to mouth, like Boucharet. We're trying to slowly but surely build a network that is aware of these challenging behaviors and how they can be related to brain injury. And we're actually going to start a new phase in a couple of weeks where we're going to try and build an intervention in community settings for people who have difficulties related to acquired brain injury. So we're going to start that out maybe December.
As soon as we have ethics approval,
yeah.
This is the answer.
Do you want to complete?
No, well, the training is a huge piece, and I think community organizations are asking for that training, for that sensitization. So the short answer is yes, it's possible. I think it's possible to do that, to sensitize, to have like interactive, adapted to the right level sensitization and training. Like people understand brain injury, they understand the behavioral consequences. Sometimes the challenge is that we are dealing with complex issues, and participants do have ABI and mental health and substance use and physical health issues coexisting. And like for some of these issues, you need a neuropsychologist with like years of experiences. And I think we need to acknowledge that and have training and resources and support for the community organizations. It's this balance between the two of like, on a besoin de formation, puis aussi on a besoin, we need to recognize the moments where we're never going to have that level of knowledge in the community sector, but the knowledge we need to have is like, okay, we've reached that point with this person, we have a blockage in, the interventions we're doing, and now we need to have fast track access to rehab people. So yeah, does that answer kind of your question? But we're I don't know how to say that. We're also actively working with Santé Québec and the ministry to be able to move forward with this project and turn this into a pilot intervention. But we can have private discussions on where this is going.
Very cool. Thank you. Move here and then over there. Yeah.
Hello, I'm Gallo. I'm a researcher in Toronto with the Salvation Army. I feel like all of your talks were variations on a theme. In the cascade of care, you've all sort of identified that some people fall through the cracks. Should shelters start screening for ABI now, is my question. I understand that a lot of the tools you mentioned are very specialized, require a lot of training in some cases. I was looking at okay, cool. So that's the question. And also thank you for your work and for broadly all of this.
Yes, great. Thank you. Oh.
Should they start screening for ABI? Yes, but unfortunately right now, I'm not convinced that it will lead to accessing health services that are adapted to the needs of the people who will screen positive for the acquired brain injury. So right now the services are just not available in Quebec, or they're poorly adapted. But the screening is really easy to do. It's a basic like questionnaire that everyone could use. It doesn't require much training. It's very effective. But yeah, the services right now are just not available or just not great. So we're trying to test things out in community settings. But yes, definitely start screening, I think, to maybe understand some of the behaviors better as well. I find that there's a lot of diagnosis overshadowing right now. So we'll meet a lot of participants who have a personality disorder diagnosis. Antisocial or borderline. But when we start speaking with the person and we understand their history of acquired brain injury, we may understand that some of these symptoms can be related directly to the brain injury, and maybe they don't have the proper diagnosis because we just didn't take the time to screen for possible brain injuries in the health network.
I'm just gonna add to that, and I think it's a very good answer that what are you screening for? Like, well, you're screening for brain injury, but what's next is always a question. And we've had conversations with community organizations, and we just had to be aware that for some people having a positive screening, is it going to impede their life in any way? Is it going to be an extra label on them that's not useful? For a lot of people, the label is useful because it's going to allow them to access services. And in that case, I think screening is important. But you just need to keep in mind that if, this person is, I don't know, trying to recover the custody of their children, and, they have that extra label where, it might mean a lot to have this extra diagnosis and it's not useful for them, then you need to kind of question that. Just want to add that kind of caution. But yeah.
Great. We have one question here and then one here, and then we might have to, okay, probably that'll be our last one, I would think, yeah.
Hi, everyone. Thanks for your presentations. I'm Kristen, and I work at a youth serving organization in Guelph called Wyndham House. And we operate shelter, supportive housing, and also housing first models. And one of the things I'm wondering about as we think about what our community needs to do next is really the population we've both presentations talked about, where there's a lot of complexity, where someone's living with like chronic and severe multiple things going on. What kinds of built form or structure would you recommend? Should we be thinking about more specialized kinds of housing structures, or more housing, like act-based housing first model? I think I'm just wondering what we should be focusing our advocacy on for this population, because I agree we've made a lot of progress locally around screening, and we have access to and pathways to care, but it's not meeting the housing and support needs of the population we're trying to serve.
I feel like I've talked a lot, but
for both, all of you.
Well, I think multiple models, like there's not a one good fit. One thing we've in this project, we've partnered also with TBI community associations, like traumatic brain injury associations, who are not people we've used to know. And one of the things they were saying is that actually they don't have enough housing and accommodation for people with severe behavioral issues, for instance. And coming from the brain injury sector, those people also fall through the crack, and then they come to the homelessness sector, for sure. So those kinds of solutions, I think, would be needed. They just don't have enough specialized accommodations, for sure. But it's not the only answer, because we're always in this challenge where there are people kind of, being fueled into homelessness because of the failures of the disability sector. But then there's also people who are experiencing those challenges that they've never encountered the disability sector. And we also need to think about those needs. And I kind of think that like mobile health teams, or more flexible kind of supports within the community organizations, like what the participants told us is that despite the challenges, they were able to, build trust with community organizations. They appreciated those spaces, even if they were not perfectly adapted. So so in those situations, I think having health professionals come and support community workers, support community spaces in community spaces is one of the solutions. Multiple. We also did a lit review, but we haven't presented that here. And there's also multiple models. Just want to add, because I don't know why you made me think of that, but a lot of studies in detention center, because a lot of people in detention have also complex health issues and acquire their brain injury in detention. I know I'm not surprising anyone, but there's a lot of violence in the detention centers, and that can result in brain injury, and it's completely unrecognized. And so having those health teams in detention centers, in youth protection, well, basically what you were saying applied specifically to this population. So not forgetting child protection and detention centers and that. So I'm not giving a super satisfying answer, but there's multiple models that could be thought about depending on the specificities of your population and also the services that are already in place.
Here.
Hi, my name is Sarah, and I'm originally from Kitchener-Waterloo. I work for the YWCA Cambridge. And I've been somebody that was so privileged to have a leader that was very different for many, many years. And so we were trained on ABIs 10 years ago. And one of the things I think of frontline workers, being able to give frontline workers the tools that we are going to need so that we can feel better about connecting with folks that we can't do anything for. We can't solve, fix, or cure what they're going through, but I can at least try to understand the behaviors that we're seeing and the complexities that we're seeing. And so I can put those aside and I can still love the human. I can understand those complexities in whatever medical terms I was taught in, and I can still love the human, right? And I can see how the system is complex and there's nowhere for me to send that person, and I can still love the human. And so I would love to encourage everybody to not be fearful of giving tools and knowledge to your frontline workers. They're going to understand there are lines. We'll stay in our lanes. Once in a while, when we really see injustices, that's when we jump out of those lanes. But otherwise, giving the younger staff the tools and the knowledge that they need to be able to understand the complexities that we're existing in. And that if we see those complexities as insane and crazy and just spinning, what must it be like to live in that, right? And so continue to share this information. It's amazing. There is those screening tools are helpful to us, again, because then we can understand that those complexities exist, but alongside that human, and we can still love that human. So thank you.
Beautiful, thank you.
Thank you.
Well, encouragement to keep doing the good work you're doing. Thank you so much for sharing that. Okay, Stephanie, take it away. Stephanie's like, I gotta follow that.
No, I think this is a nice follow-up to like the last few questions here, and it's kind of for everyone, and a little bit off, going rogue here, but I'm thinking about the health services, so like emergencies, doctors, professionals there, and then also the amount of pressure. So I'm a researcher from Ottawa and CHEO, University of Ottawa and CHEO. So I'm not a frontline worker, but I just feel like we put a lot of pressure on the frontline service staffs to understand all of these complex cases and take care of all of these complex cases. And the medical staff, on the other hand, so like emergency room, the trained neuropsychologists and things like that, that understand like the science and the care for it, who studied to care for this. To what extent do we need to have intervention for that training for new medical professionals, just around active listening, kindness, compassion, and like listening to the individual and their experiences? Because I was really thinking about it with all of the questions, and then also with the example of turning to substance use for everything. You know, we just find the easy check off. So are we missing that component of training with kindness for individuals who are, you know, lower income, more socially diverse, like having very extreme situations?
I can start with something, I'll let you complete. I think there is some form of training in the new programs, at least what I'm seeing in OT at Université de Montréal. Laurence is starting integrated.
Also medicine.
Also medicine, yeah. There's like un vent de changement, like there's that willingness to change. I think what is happening, what I'm seeing right now in Quebec, I practice in a community setting as an occupational therapist, and what we're seeing is a lot of, it's not going great right now in Quebec. It's just not, it's not a good moment right now. New laws coming with a lot of pressure to perform, see the most patients you can, like 4 patients an hour. Like it's just, people are tired. People are trying to do their best within these circumstances, and I think that can explain to some extent what we saw with our interviews. Not all, but it's a difficult times right now in the healthcare system. But I think the training is getting better regarding treating with kindness, trauma-informed practices. We're getting there. It's just the setting right now it's not great.
Anyone want to add to that? Good. People are ready for lunch. Okay, we are going to close out the session. Again, just want to say a big thanks to our presenters being on the hot spot. You did a great job answering all those questions. That was amazing. And want to thank you all for hanging out here the last few minutes. And love that we're kind of leaving off on this conversation about kindness and compassion and love. So have a lovely lunch. Enjoy Jessie Thistle, amazing speaker, and have safe travels back to your communities, everyone. Thank you.